Hey, hello, everyone. We would like to welcome you to our continuing education hosted by the UNC Department of Nutrition and Dietetics. We always appreciate an opportunity to gather our preceptors and other professionals in the field who can benefit from these topics. So thank you so much for being here. We are very excited to have you. Okay, so it is requested by the Academy of Nutrition and Dietetics that we share this disclosure prior to any continuing education that we offer. This basically is saying that CDR is not responsible for how we, the provider, interpret the code of ethics. And then in terms of conflicts of interest, I have none to disclose for today. Before we dive into our agenda, to our content, a couple of pieces of information to share. So you are welcome at any time to type questions and comments into the chat, and I'm already seeing a couple, so thank you. I love seeing that participation. There will be times that we pause for questions, at which time you're welcome to unmute yourself. Otherwise, we ask that you stay muted in order to prevent background noise, and our assistant Paris will be helping make sure that we have everyone muted as we go. We are delighted to be able to offer you 2 CPEUs for those of you who are attending live today and for the full session. As you may know, CDR requires RDNs to obtain 1 CPEU related to ethics or related to health equity. So today's CPE will cover that for your recertification cycle. We will also provide you with a CE certificate for you to keep on record in the event that you are audited and you need to provide record of CPE attendance. So Paris, our graduate assistant, is assisting with that process. You are welcome to email her and after the session, and she will distribute the certificate in the coming days, as depending on how much of an influx we get. And I'm sharing her email in the chat right now. You are also more than welcome to email me, brianna.williams@unco.edu, whether it's for the CE cert or for any questions that you may have. I'm always here to be of assistance. Lastly, as usual, we are recording this session so that you may rewatch it and share it with others who you feel would benefit, or for many who have expressed interest who are unfortunately unable to be here live. With that said, we want everyone to feel comfortable speaking up and sharing their experience. So I would love to give you the opportunity, if after the fact you decide that something that you said, or even just sharing your name with the group and introducing yourself, you decide you don't want that to be on the recording, please let me know and I will work out a way to edit that portion out if you're uncomfortable. We want everyone to feel comfortable. And so that means for those of you who may be watching this recording, if there's a choppy cut, that's probably why. So I just wanted to give you a heads up. I will also be sending a survey link in the chat, and I will send this toward the end of the presentation as well. This survey includes questions that CDR asks us to ask you. So if you don't mind taking a few minutes to complete that survey once we've concluded our session today, that will help us inform our future continuing educations and continue to make them the way that you would like them. As for today's agenda, we will start, depending on how much time we have, by opening the floor to our attendees who would like to introduce themselves. We always encourage that you introduce yourself so that we can make this more of a collaboration rather than just a presentation. And we want you to be able to get to know each other. So depending on how much time we have before Dr. Bach begins at 3 o'clock, we will start some introductions. I also have some updates and information to share. And depending on how the timing works out, I will either do that right after Dr. Bach presents or after Dr. Withrow presents. But we wanted to make things kind of flexible in terms of timing because we have our 2 wonderful but very busy speakers with us today, and we want to be mindful of their time. So of course, we also, as the reason most of you are here, it's for Dr. Bach and Dr. Withrow presenting on their topics of neurodivergence. Something else that I would like to mention is that as I've mentioned, and I probably will say again, we encourage you to share questions and share your experience. With that said, if you have a specific scenario that you're sharing, whether that be with a particular student, intern, colleague, or even maybe a former preceptor of your own, we ask that you be vague with that so as not to out who that person might be, with the understanding that we are all here as professionals, but that this, there may be students watching this recording to educate themselves, and other, colleagues who maybe you don't see their names here in the live presentation, but who may be watching the recording afterwards. So with the few minutes that we have before Dr. Bach begins, we're going to start with some introductions. So anyone who's interested, you are welcome to either type who you are in the chat, or you can unmute yourself to introduce yourself. And there should be a React feature where you can raise your hand. So if you are interested in introducing yourself in order to maintain some semblance of order, and to not put anyone on the spot, you're welcome to use that hand raise feature. And so I will start. Many of you know me, but if you don't, my name is Brianna Williams and my pronouns are she, her, and hers. I am the program coordinator for UNC's DI and MSDI, and I've served in this role since 2022. Prior to that, I lived in Baltimore, where I was a critical care dietitian and a preceptor for the Johns Hopkins internship. So that's a little bit about myself, and I don't think I see any hands raised yet, so I'm going to go ahead and let Paris introduce herself next.
For sure. Hi, everyone. My name is Paris Russo. My pronouns are she, her, hers. I am a graduate assistant with the department. I'm also a student within the MSDI program. I just started my second semester. I am from Temecula, California, so still enjoying some nice, like, spring-ish weather for those living in Colorado comparatively. And I'll be helping out with the CPE cert. So again, if you need my email, it's in the chat. I'll post it again throughout the presentation, and look forward to hearing this all with you.
Okay, and so I'm just going to stop sharing for a moment here. We've got a couple of people in the chat who are introducing themselves. So looks like we've got Gina O'Brien. I have the honor of precepting UNC dietetic interns, and I have loved ones with neurodivergence. Thank you for providing this information. And Gina was actually our preceptor of the year last year. Gina, thanks for being here. We've got Lisa Caldwell, whose pronouns are she, her, joining from UNC in Greeley. Lisa is our DPD director and distance dietetics coordinator. We've got Linnea Hand, she, her pronouns as well. Linnea is from Metro Caring, which is in the Denver metro area, who is the nutrition manager and RDN for the community rotation there. Jenny Jackson, she, her, joining from Oregon State University and the MSDI program director. Welcome, Jenny. I thought we might have a lot of educators today, directors and instructors, so that's wonderful. We've got, okay, hang on, I'm sorry, I'm getting lost in all of these. Okay, Lily, she, her, hers pronouns, joining today for class from UNC. Amazing. We've got Betsy Wagner joining from Fort Collins and an MSDI alum. We love hearing about our alums. Thank you today for joining, Betsy. I'm going to keep on going. Anne Mahone is here, also from UNC. Anne is an adjunct instructor at UNC in the Kind department. Pronouns are also she, her, and hers. Let's see. We've got Steph Finelli, who is also coming from UNC, an assistant professor. Welcome, Dr. Finelli. It's great to have you. And it looks like we've got quite a few in here. So instead of continuing to read these aloud, I will allow those of you who are here today to kind of scroll through and get to know everyone. I love seeing this participation. So let's keep up that work. I'm not sure if I mentioned this before, but we are taking attendance to track through CDR. And that way we can also kind of keep track of who is needing needing the certificates. But as we mentioned before, especially for those of you who maybe just joined us, Paris Russo and myself will be distributing the CE certificate after the fact. And so as we go through the presentation, because I know some of you, we oftentimes have people who are who pop out because of internet loss and that kind of thing. And so we'll keep you up to date in terms of links that you'll be needing, email addresses that you'll be needing. Paris just put her email again in the chats for anyone who maybe joined a couple of minutes late. So thank you all. My gosh, it's so wonderful to have this overwhelming activity in the chat. So thank you. Continue to use that chat. Paris and I will both be monitoring it. And for any questions that are for Dr. Bach, we'll be sure to address those either as they come in or toward the end of the presentation. But thank you. Please keep typing in the chat and we will keep learning everyone who's here. Thank you so much, you guys. Okay, so I'm going to reshare my screen and we will move forward with our presentation. All right, and let me know if you ever lose access to my screen so that I can readjust. So the last introduction that we have is, at least for this moment here, is for our first presenter. Hi, Dr. Withrow. Our first presenter, who is Dr. Bach, Dr. Josh Bach, who is joining us today from Fort Collins. So the objectives for Dr. Bach's presentation are listed here on the screen. We will be covering components including increasing clarity and understanding of how neurodivergence is impactful in the education sense, particularly in dietetics education. And the hope is that by the end of today, you will increase your felt confidence when it comes to educating these students and these interns who are on the neurodivergent spectrum. So Dr. Bach was with us for our CPE that we held in the fall, and he was invited back after an overwhelmingly positive responses and feedback and requests for a part 2 or just an extension of that first presentation. With that said, if you did not see that presentation, not to worry, Dr. Bach will be providing an overview of neurodivergence that will equip you to participate today. As mentioned, we always encourage you to participate through the chat function if you have questions at any time, as we hope this is a collaboration and a discussion of these scenarios, more so than just a presentation, since we humans often learn best by doing and by example. So Dr. Bach will be giving some information for us, and then I will take some time to share some more information about our programs before turning it over to Dr. Withrow. But I would love to provide a brief introduction of who Dr. Josh Bach is. Dr. Bach is a psychologist who conducts therapy in Fort Collins as well as remotely through his practice called Bach Psychological Services. His areas of specialty range from management of anxiety and trauma, working with the LGBTQIA+ community, to helping those who are on the neurodivergent spectrum cultivate pro-social behaviors. His experience spans from adolescence through adulthood. Dr. Bach obtained his undergraduate degree from the University of California, Berkeley. His doctorate in clinical psychology is from the University of Loyola, Maryland, followed by his clinical doctoral internship right here at the University of Northern Colorado. And in addition to his Bach Psychological Services private practice, his experience also includes crisis responding for mental health crises in Northern Colorado. We are so very grateful and excited for your time today, Dr. Bach. So with that, you are welcome to share your screen and take the floor.
Awesome. Awesome. Thank you so much, Brianna. I really appreciate the very warm introduction. I am Going to try and multitask briefly. Does everybody see my screen and not my presenter notes? Everybody just my
Yes.
screen.
Yes.
Wonderful. Awesome. So, first and foremost, I just want to give such a heartfelt thank you to everybody who came to the first part, everybody who requested to have me back. Was just blown away with how helpful everyone seemed to think my presentation was, and just the warm response. Today, I'm going to take a little bit of a different approach. So if you've seen part one, if you were part of part one, it's very content heavy. It's very educationally focused. There's just a constant stream of me talking, which I enjoy as much as the next person. However, today I kind of want to take a little bit of a different spin. So what we're going to be doing, for those of you that either personally, it's been a couple months. If you haven't reviewed the content since then, or if you weren't able to be in part one, that's totally fine. We're going to be dedicating the first bit of this presentation just to kind of giving you the broad strokes, the overview of what I spent about an hour covering in my previous presentation. But the way I want to kind of set this up a little differently today is I want to maybe slow down a little bit and elicit some more thoughts, questions, experiences from folks out there in the audience. I would love. In fact, I'm going to make sure I have access to and I can see the chat. How do I do that? Oh, there it is. The chat is right there. Let me make sure I have it up. Beautiful. Because I definitely want to make sure I am able to catch your participation and hear your thoughts. It's kind of what I'm going for today, to kind of emulate how one might work with somebody with neurodivergence, being more integrative with folks who have difficulty with attentional, with sustained attention, with executive function, with things like that. I'm really hoping today can be more of a modeling of that kind of behavior. So as Ms. Williams said, my name is Josh, Dr. Bach, whatever you want to call me. I'm totally fine with most things. I use he and him pronouns. As Brianna said, I have a private practice out here in Fort Collins. I've been working with queer folks, been working with neurodivergent folks, been working with folks with anxiety and stress-related disorders for about 10 years now in varying capacities, all the way from being a special needs camp counselor to a Dungeons and Dragons dungeon master for folks who are looking to expand their pro-social skills, to now having the private practice. I am exceedingly fortunate to do the thing that I love most, and I am so very thankful to be sharing it with you all today. So let's jump in. Beautiful. So as I mentioned, we're going to kind of do a really maybe briefish, I like to talk, a briefish recap of neurodivergence, what that looks like, common expressions of neurodivergence. We're going to be talking about DSM diagnoses. We're going to be talking about symptom presentations. We're going to be talking about some of the fun key terms that you'll hear used by neurodivergent people, used about neurodivergence. We're going to be talking about kind of what you as preceptors, educators, mentors, supervisors can kind of grab onto tools wise. We'll talk about my leaving the door open mentality, policy, acronym, whatever you want to call it, as well as knowing your role, knowing in what way you fit into these different kinds of scenarios. I've got a couple tips and tricks. And then one of the new things I'm also bringing into today's presentation that was not in the previous presentation is we have a vignette that I have from the previous presentation, but I've also kind of created a walkthrough sequence of an experience you might have, or might be similar to an experience you have with a student, to really kind of give you a guided step-by-step. This is how you can kind of implement some of the tools, some of the knowledge that you're going to be learning today, or have learned in the previous presentation, and are going to be applying and deepening today. As that was some of the feedback, maybe not directly that I received, but some of the questions seemed kind of very oriented around, okay, this is great information. I appreciate you letting us know, but what about this? What about that? How does this look in the real world? So my hope is to kind of take a stepwise approach to give you all a bit more about what that can look like in an applicable way. So, recap. This is where I would love your participation. When you see the word neurodivergence, what comes to mind? What kind of, what falls within this category? What kind of experiences are within this category? I would love to see you all in the chat, kind of just what comes up for you first when you see the word neurodivergence. Autism. Yep, absolutely. It's a spectrum. Communicating and processing in a different way. Absolutely. Variety. I love that. Differences in processing. Spectrum. Yep. Absolutely. Absolutely. Well, yeah. I mean, I think that, yeah, variable processing of information and communication, different experiences with environment. Totally. Students not being able to, yeah. Spectrum, student not being in group work or project. Absolutely. Awesome. Let's keep them rolling in. I don't want to cut anybody off as they're typing, but yeah, this kind of notion that there is this variety, there is this spectrum, there is this kind of broader category of human experience. Now, what do we kind of mean by that? And how does that show up? And what does it look like? And one of the things I really highlighted last time we all got together was some of the most common diagnoses. Now, we can sit here and walk through, and I'm happy to walk through the different diagnoses that are most common to the DSM-5 TR, the kind of um, the holy grail, so to speak, of psychology and how we diagnose things and how we understand different diagnoses and mental health related illnesses. But the thing I want to do before we dive into each specific disorder is I really want to impress upon you that diagnosis is at baseline only important for folks like myself, providers that are doing mental health counseling, psychological work, and or medication management. And the reason I make that distinction is not to say that there's no other place for diagnosis or there's no other importance therein within or with diagnoses, but really to say that I would encourage you all to stay away from, okay, what is this student's or what is this intern's diagnosis? And the reason I say that isn't because I don't want you to care about these folks, but because of the stories that I hear so often. Now, the ways in which diagnoses can pigeonhole students into certain experiences. For example, I have a client, I'm going to call her, this is obviously not her name, but I'm going to call her Stacy. Um, and Stacy comes to me one day and she says, Dr. Bach, we've been working together on her autism diagnosis. And one of the big things I work on with a lot of my folks is, first of all, understanding what the diagnosis means to you, how it shows up in your life, and also how do you share these diagnoses with people that it's important to share with. Now, what I mean by that is, maybe your friends do or don't have to know, maybe your family does or doesn't have to know, but a lot of neurotypical or neurodivergent folks struggle in a classic neurotypical workplace because there are certain misalignments with the way that they show up. So I often recommend to folks that they try to disclose this information to trusted supervisors, mentors, bosses, whatever. Now, keyword being trusted. So Stacy comes to me and she shares that she has finally shared this with her boss. She's very excited, really feels really good about herself, and we're celebrating and we're very happy. And about a month later, she comes back in very dismayed and very frustrated and confused. Now, funnily enough, Stacy is a dietetic student who is in a hospital setting and is very excited about working with pediatric clients. Now, after sharing this diagnosis of autism with her supervisor, she was pulled from all pediatric clients kind of without much warning. And we spent a lot of time in therapy processing this and getting Stacy to a place where she could more directly ask why this had happened. Now, what had occurred was Stacy's supervisor, believing that all folks with autism are highly sensitized to sensory input, wanted to preemptively pull Stacy from PEDS rotations because in this person's mind, well, children are loud, they're very unpredictable, there's a lot of sensory overload. So in keeping with what she believed was going to be the best for this student, she ended up pigeonholing her into some more colloquialized understandings of autism. Now, again, this comes from a place of wanting to help Stacy, wanting to help her succeed, and not wanting to stress her out or submit her to undue anxiety or stressors. But what I encouraged Stacy to do, which she thankfully did, and this supervisor of hers was very open to discussion, was to let her know this is actually not how my autism manifests. This is actually pretty discriminatory. And it was a really wonderful moment where Stacy was able to speak for herself and was able to kind of share her experience. And this supervisor was able to learn a bit more about how her well-intentioned actions actually had pretty negative consequences. So again, the reason I tell you don't worry about these diagnoses isn't because they don't matter, but because they can come with biases. They can come with whatever lens that is brought to those kinds of experiences. So typically, I've actually learned from that experience, and now I encourage folks to talk about to being someone who is neurodivergent and sharing how that shows up, rather than maybe sharing a specific diagnosis, because it can have those kinds of effects. So with that, broadly speaking, I'm actually going to, if you do, here's what I'll say. If you do really want to know point by point, autism, ADHD, so on and so forth, you can check out the first presentation. There's a bunch of awesome information there. But I think for the sake of maintaining this kind of notion I want to put forward today about trying to take a more curious approach, which we'll talk about in a little bit, rather than a I know what this is or I'm already informed kind of approach, I'm going to refrain from going into all of the nuance of all these different things. But again, if you're curious, check out my other presentation. I know that I'm pretty sure we're going to put a link out with the original email invite. So let's bounce right along. So broadly, let's talk a little bit about some of the symptoms of neurodivergence, some of the things that are most commonly experienced by folks who are neurodivergent. So firstly, being executive functioning. Now, executive functioning is everything from what do I want to eat, 3 nights from now, all the way to how do I organize my schedule to make sure I'm having enough time to both see patients, clients, and chart about them, to, how do I make sure that I'm balancing getting to work on time with, going to the gym in the morning. So these are quite difficult, or can be quite difficult things for folks who are neurodivergent. Now, one of the reasons that you'll notice this is there's kind of this cluster, executive functioning, dopaminergic functioning, social nuance, and I think attentional difficulties all are part of the prefrontal cortex, which is what we notice as being either underdeveloped or differently developed with folks who are neurodivergent. Now, this isn't broad spectrum, every single person, but these are some of the more common things that we notice in brain development that is different for folks with neurodivergence. And what that impacts is things like executive functioning, is things like dopaminergic functioning. And I'll kind of talk you through a little bit. One of the other big things before I get to all of that, one of the other big things, kind of just making sure I'm going in order. Sensory hyper or hyposensitivity. Hypersensitivity meaning that, lights can be too bright, sounds can be too loud. Having too much movement or too many people in a space can be overwhelming. Now, as a generality, we tend to associate hypersensitivity with folks who are, when I say higher functioning, I mean more readily able to take on the tasks of a neurotypical, or not a neurotypical, pardon me, take on the tasks of a solo functioning adult. Whereas hyposensitivity, folks who experience a reduction in the intensity of the different sensory experiences they have, tends to be more greatly associated with folks with lower functional capacity. So folks who are nonverbal, folks who are maybe requiring a caretaker. Not to say that this is, again, one-to-one, everybody experiences this way, but that's how we tend to see it. And so when you're working with neurodivergent folks, there is, again, never making assumptions, but there is likely a greater likelihood that the folks you're working with will have more tendency towards hypersensitivity versus hypo. I'm going to take a drink of water because my mouth is dry. Dopaminergic functioning. Now I could really get down in the weeds with this, but essentially it's one of the explanations for neurodivergence, that the reason that we see increased activity is to generate increased amounts of dopamine. Oh, I saw a question. I am going to finish this slide and then I'm going to jump onto this question. I'm going to lean into what I shared earlier, and I appreciate that question. So dopaminergic functioning, your brain processes dopamine differently, which is your reward system, which is your movement system. And that's kind of one of the explanations that science has kind of come up with related to why we see neurodivergent folks typically engaging in sensory seeking behaviors, fidgeting, stimming, over communicating, or pardon me, over talking, things like that. With regards to social nuance and interpersonal functioning, interpersonal processing, and kind of, again, we see a lot of development of self and development of other in the prefrontal cortex. Development of other, what a way to put that. Understanding of social nuance by understanding of other in context. Now, one of the interesting things we see in the research is that folks, and this typically levels off at about age 25, but folks who are neurodivergent tend to have 0 to 2 years of social emotional delay, in relation to neurotypical peers, which can cause this difficulty in understanding those around you. Now, for certain folks, this could be even more difficult, where there is a lack of theory of mind, a difficulty understanding how others can think differently than one thinks. This can be as simple as just not having the proper tools to understand when context switching is appropriate. I work with a lot of clients about code switching, how to show up for your patients, for your supervisor, for your colleagues, for your, maybe the head of the hospital, and how to navigate those kind of different professional relationships. Neurodivergence can also have an impact on intelligence. Now, this is not a broad one-to-one kind of thing. The reason this is included in the slides is because intellectual disability and neurodivergence can typically co-occur. So somebody with a particularly low IQ may also experience symptoms of ADHD or of learning disabilities such as dysgraphia, dyscalculia, so on and so forth. But I want to be very clear that being someone with neurodivergence does not by any means, by any stretch of the imagination, inherently indicate intellectual differences or difficulties. Similarly, speech and language difficulties and differences. We talk about dyslexia, dyscalculia, dysgraphia. As we look at reading, as we look at speech patterns, we also can see more of monotonic speech when we talk about autism to a certain degree. A lot of the rest of these that I'll talk about, learning difficulties, movement and tics, attention, have such a wide range to them. For example, with regards to learning differences, we talk about a greater propensity for visual learning, or what we call combination learning. So visual and auditory, to try and really, when we talk about folks with neurodivergence, it's often that combination learning is going to be the best. So I am hearing you talk about the thing, I'm watching you do the thing, and then shortly thereafter, I am doing the thing as well. That really helps to reinforce and integrate important knowledge into the neurodivergent brain. Movement and tics really kind of loops into dopaminergic functioning. You'll see, there's the very classic kind of colloquialized autistic flap. What that typically looks like in a day-to-day basis is more of this like fidgeting type behavior, or more of kind of like a hand rubbing, or it's not nearly as aggrandized as it's made to be in a lot of popular media. But again, these kinds of flapping or ticking or movements either serve the function of sustaining attention, creating extra dopamine, or alleviating stress, alleviating tension through physical engagement with the environment. Similarly, sustained attention, which it's so funny that sustained attention is part of this slide, because this is the most yappy slide that I have. Sustained attention can be much more difficult for folks who have dopaminergic processing difficulties, because that same amount of dopamine that's required to sustain your attention may be difficult to hit that level, and it may be difficult to maintain that level without some sort of alternative engagement strategy. So, oh, that was so many words. I'm going to jump over to this question by Linnea, and I hope I said that right. I am a preceptor, and I ask interns.
You did.
Oh, yes, awesome. I am a preceptor, and I ask interns about their access needs and work style preferences via a written document they fill out, and then we talk it through. I specifically list neurodiversity as well as lactation. Oh, I love this. Work environment, ability, caregiver responsibilities, bathroom access, saying that I want the rotation to be a great and inclusive experience for them. Is there a better way that I can ask about this to make sure they feel safe and supported in sharing what works for them? First of all, Linnea, I love this. This is amazing. I love that not only do you ask about accommodations, but you ask about a wide variety of accommodations. I think one of the things that can be so difficult for folks is I'm the thing on the list. I am the reason or the problem or the thing on the list that now has to be distributed. So I love that you include so many different need cases, because it really shows that you're striving for curiosity and inclusivity rather than trying to target a specific group that you think is going to specifically struggle. I think the only thing I will say is I love having it written, because then you can re-reference it. I also think that it's a great opportunity to start the conversation, which is what it seems like you're doing. Here's this document. I'd like you to fill it out. Then we're going to have a chat about it so I can have a better understanding of what you mean when you say X, Y, and Z. I love that. And I really think that, that gives the opportunity, and we'll talk about the open strategy later, that gives this amazing opportunity for you to kind of name yourself as someone who cares, give folks the opportunity to advocate for themselves, and also provide an opportunity for you to learn more about what's going on with the folks that you're working with. So no notes, spectacular, absolutely so well done. All right, so let's bounce right along. This is one of my, oh, never mind. My presenter mode got me confused for a second. This is one of my favorite slides that I think I've ever made. It is so enjoyable for me to share these different key terms with you all, because they really show up so much when we work with neurodivergent populations. And I would love, especially for the sake of time, I would love for you all, if you see a term that you recognize, I'd love you to throw that term in the chat, as well as what you know about that term, what it means to you, what its definition is. I would love to just kind of throw this out to you all. Oh, Carrie, absolutely, I hear you. Overstimulated, yep, too much going on, brain shutting down. Too much power to the system. And also, if you get it wrong, that's okay. This is a no judgment zone. All right, hyperfocus. People are paying too much attention. Ooh, I want to stop on that. So Sharon, I love this. I love this thought. So hyperfocus is when people are paying too much attention to one task at the detriment of other things. So I'm going to give you a half a point. That's a yes and. So hyperfocus can certainly be over paying attention to the detriment of other things. And folks also will use it colloquially to talk about being able to engage with a singular topic for long periods of time. So it doesn't necessarily have that kind of second aspect to it of it being to the detriment of other things, though I do talk a lot with folks who have over engaged with their hyper focus and have fallen behind in other ways. So I love that you brought that point up. That's awesome. Masking is when a person says or does something they think someone expects them to say or do. Yep. How am I quote unquote supposed to show up in this social experience? I'm going to put on the mask of quote unquote being normal, which is what a lot of clients talk to me about. And how do I do that so I'm successful in certain environments? Unfamiliar with double exceptional. I will get to that absolutely. I too am neurodivergent. Familiar with all these? Heck yeah, Nancy. Love to hear it. Echolalia. Yep, repeating a word or a phrase. Masking, running on the outside of the racetrack to get as far as the people on the inside of the racetrack. Ooh. Oh, Linnea, I like that's an interest. I have not heard it described that way, but I like that. Essentially working much, much harder to do the things that everybody else is already doing. Safe foods. Yep, foods that do not cause fear or anxiety absolutely carry. The other thing I would say about safe foods are that they don't have any sort of sensory impact, whether it be texture, taste, temperature, things like that. These are foods that I know that I can consume and not have to worry about how my body is going to react. Double exceptional, neurodivergent, and gifted. I have an autistic kiddo. Yes, I love that. Yeah, double exceptional is very much this notion primarily used in educational settings where and I kind of go back and forth on how much I enjoy this term, but essentially like this child is exceptionally good at X thing and exceptionally struggles at Y thing. So kind of this how it can be kind of both and. You know, you may have a child that is brilliant, absolutely so intelligent and so, you know, scores at the top of, you know, standardized testing, but you know, has so much difficulty raising their hand in class or completing their homework or, you know, participating in group assignments that they are falling behind. Safe foods. Oh, yes, RFID is a huge, huge example of folks with safe foods. Um, can be anything from food with the texture, color, risk of reaction, allergies. Yep, do not cause fear and anxiety. Predictability, love, 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 love. I literally made a grilled cheese sandwich with slightly too much mayo last night and his alarms went off. It was no longer, yes, oh my gosh, yeah. So these things can be so, so specific. So specific. So I'm going to go through them just briefly. I want to make sure we have enough time for our vignettes and so on. So stimming is any sort of motoric behavior, whether a gross motoric or fine motoric behavior that is engaged with for the sake of maintaining a homeostatic medium, whether it be increasing dopamine production in the brain so that the person can focus more, or it be releasing anxiety and stress through movement. Now, this, as I've mentioned a couple of times, can be these kind of very colloquialized or maybe televised, whatever, behaviors like arm flapping. They can be as small as, you know, you may have someone who has a quarter in their pocket and they're just sitting there and, you know, kind of wiggling it around. This is, you know, can be anything from playing with your fingers, playing with your hands, playing with different fidget toys, to things like echolalia or echopraxia. Echolalia, someone mentioned, is repeating sounds. So one of my favorites is whenever you cross the sidewalk and the sidewalk, the little walking person goes and it says walk sign is on. That is one that I work with a lot of kiddos that one just boop triggers it because it's a very specific sound. It's a very specific intonation. It's a little bit goofy and it just comes right out of the mouth. And echolalia is pretty common. One of the things I have to work with folks on relatively frequently is if you're working with someone who has an accent, neurodivergent folks have a tendency to adopt accents, which can be perceived as very rude. It's more than likely unintentional. Echopraxia is copying a movement. If you have somebody who's very expressive and gesticulates a lot, you may have a neurodivergent person who like starts to also gesticulate a lot. Overstimulated, as was mentioned, sensory overload, masking is essentially putting on the quote unquote normal or the quote unquote acceptable version of yourself, putting that on to go out in the world to have less difficulty interacting with other folks. Mirroring is similar to echopraxia, echolalia. You'll notice a lot of neurodivergent folks who are very tuned into what the people in front of them are doing through a history, a lifetime usually, of social interaction difficulties. They're typically very engaged with what's going on in front of them, making sure that they are mirroring the person's posture, their vocal intonation, their facial expressions, their just kind of the general energy that they're putting out, which I say makes neurodivergent people spectacular storytellers and story receivers because they are so engaging and so engaged. A special interest topic is typically something that is associated with a hyperfocus, whether it be I don't know, whether it be woodworking or it be trains or it be just some random topic that someone has just kind of latched onto and will become a doctoral level of understanding of it within a matter of a month. Now, obviously, I'm joking a bit. There's a bit of hyperbole there, but special interest topics are typically things that people who are neurodivergent, now this is more typically associated with autism, but folks who are neurodivergent broadly tend to really engage with and feel really excited about. I talked about double exceptional. Neurospicy is a term that a lot of Gen Zers are using. I would encourage you to be careful using this if you are not neurodivergent yourself. I wouldn't say it's, on the level of like only neurodivergent people can say it, but depending on your crowd, you may not get such a good reaction. Or if you're talking to some younger folks and they might just think you're really cool and hip. But I would definitely, trust your gut when it comes to using words like that when you're outside of those communities. We talked about hyperfocus. We talked about safe foods. Theory of mind, again, very much associated with autism primarily, but can be broadly within neurodivergence. Theory of mind, when you see it in children, there's a very famous experiment. One side of there's a mountain made out of plaster. The researcher's on the side of the mountain with trees. The child is on the side of the mountain with a stream. The researcher says, "What do I see on my side of the mountain?" And the child says, "A stream." How that looks in adulthood is maybe someone who shows up to a discussion about a patient thinking that their way is the way, that there's no other way you could possibly be thinking about or have any sort of potential reasoning around how we're going to treat this patient. Now, this person isn't attempting to be narcissistic, closed-minded, or uninterested in collaboration. They may just have a difficulty in understanding that not that other people have a difference of opinion, but that there is simply another thought within this specific situation. I would encourage you, if you find this kind of situation, slowing down, explaining more carefully your reasoning and acknowledging where their reasoning is or isn't correct. But I would say that probably the wrong thing to do would be to escalate, become more dug in, because this, more than likely the other person will become more dug in as well. And trying to be compassionate and understanding that some folks are not trying to be the smartest person in the room. They may just not have the immediate capacity or the immediate inclination that there's another way to go about this. Plushies I like to throw in there because it's, an awesome safety and security device that folks will use. Whether I have a client who has a plushie backpack, it's literally just like, it's a broad term, like basically just a stuffy, a plushie, some sort of stuffed animal or stuffed creation that brings comfort to the neurodivergent person. Sometimes these are weighted, sometimes they are utilitarian. Like I just said, I have a client who has a backpack that is like this really adorable like bat. It has these like little wings that flap around, but it's also has a little bit of weight to it. And I think if you turn it inside out, it like turns into a blanket, or I don't know. But essentially it's a security item that can be held or used or engaged with to help re-regulate one's nervous system. Alrighty, so there we go. How to create a neurodivergent friendly working environment. Now, all of you are all in very different places, in very different settings. So instead of trying to get every single setting and weave everything all together perfectly, what I've created, which we'll get to in just a sec, is called leaving the door open. Now, what I will say, and I'm sure this will not come as a surprise to any of you, is that you all are the gateway to these folks' future. They look to you for professional expertise, for professional understanding, for interpersonal guidance. Like the thing that you can do most, unless you are the CEO or something of a particular organization, which if you are, like definitely take this to heart and think about ways that you can make these environments more neurodivergent friendly. But assuming that most of you do not have that level of power within your organization, I would say that the best tool that you have is yourself. Now let's talk about that. So what I have done is I have written out 4 crucial steps to ensuring that your students know that your door is always open. That's why I have named this open. Out yourself, O, practice curiosity, P, experiment, E, and I purposely misspelled the no just to make it work within my little acronym. But again, the biggest thing that you can do is using yourself to help these folks with their experience of your organization. So first, outing yourself as a helper. Be explicit. I am someone who cares. I guarantee that all of you have some sort of orientation process, and it may seem obvious that you care about these folks because you're showing up and you do this job and you're a preceptor or a mentor or a supervisor, but being explicit. It is so important for neurodivergent folks to receive direct, explicit feedback, positive or negative. So out yourself. I am somebody who cares. You can come and talk to me. Please let me know if you need help. Secondly, practicing curiosity. If you take literally nothing else from this presentation, I would like you to remember this. Be curious. Don't pretend that you know. If you have someone that is showing up in a way that is odd, that is different, that is outside of the norm, be curious. Ask this student. Ask previous other folks that they've worked with. Be curious. Thirdly, experiment. Now, I know a lot of you are in very rigid systems that don't have a lot of wiggle room, that are very focused on, maybe you take certain insurances or you have certain federal or state funding and you really have to be specific in the way that you do your processes. I get that. But try to find wiggle room. Try to find ways. Is there an alternative order that documentation can be filled out that allows the documentation to be fully filled out, but goes in a different order that might be a little easier for someone with learning differences? Or that might highlight the specific things that, if you know that you're prone to fatigue, let's figure out the things that are going to take the most effort, do them first with your documentation so that they are done the best, so on and so forth. If you have a client, or pardon me, if you have a client, I have clients. If you have a student who's having difficulty with, patient care or eye contact or remembering the information that they're supposed to be gathering, taking time to role play with them, taking extra time to find that thing that might be helpful, and don't be afraid to experiment. Don't be afraid to elicit ideas from the students. They've been neurodivergent their whole life. Their whole life. So I guarantee you they've come up with a couple of tips, a couple of tricks to help themselves, and I would encourage you to encourage that. Finally, know when you're out of your depth. I am a clinical psychologist. You all are not, and you do not have to be. I don't say that to call you out or to diminish your roles or your responsibilities, but simply to say that we can be a team. Allow me the responsibility of helping folks figure out how their neurodivergence impacts their life, impacts their work. Allow me to help them figure out what it is, it's going to be the most helpful. Now, if it's, documentation, patient education, diet recall, things like that, I'm super out of my depth. I have no idea how to help them with that. But if it's interpersonal cue navigation, non-preferred task initiation, complex task navigation and completion, stimming in public, self-regulating emotion, like if it's that, I'm your guy. Send them my way. I'm happy to help them and let's collaborate. I really think it's important to not feel like you have to take on the weight of the world when it comes to any students. Ooh, Brianna, so quick. Love it. You don't have to take on the weight of the world. You really don't. Know when you're out of your depth, and that's okay. That doesn't mean you failed. That doesn't mean that you're not good at your job. In fact, I would actually argue that means you're really damn good at your, sorry, pardon me, you're really darn good at your job because you know how to help your students, how to help your mentees, how to help these folks. All right. I'm noticing the time. I want to make sure we have time for questions, so I'm going to speed along. So quickly, what is and isn't my role as a preceptor, mentor, supervisor, educator? What is your role? Keep the door open. What is your role? Listen to and believe your students. Oh my gosh, I cannot tell you the amount of times, the amount of stories that I have heard where my clients will, they get up the courage and they say, I told them, and they didn't believe me. Nobody wants to be different. And nobody wants to ask for extra help. And nobody wants to feel like when they finally get the courage to share with you how they can be successful, for you to say, I don't believe you, or prove it, or what do you mean, or that doesn't sound real, or I've never heard of that, or that's not how I understand autism or ADHD. Just believe them. Help them apply coping skills to their occupational responsibilities. I will teach them skills that they will bring to you that you can help them mold into what's going to be most effective for their roles. Finally, providing direct, targeted feedback. Now, obviously, don't like yell at your student in the middle of a patient, diet recall. But when you leave the patient space, hey, I've got some feedback for you. Are you in a space where I can provide it about how you just did? Eliciting that collaborative relationship. And this is for both positive and negative. I can tell you the worst experiences my clients have ever had are, you're doing great, you're doing great, you're doing great, you're doing great. And then summative feedback comes and it's like red tape everywhere. Don't do that to folks. Let them know as soon as it is professionally appropriate how they can improve. So, what isn't your role? You are not an expert on neurodivergence. I am. You don't have to be. Don't worry about it. I got you. What isn't your role? You do not need to pass students who fail to meet appropriate standards. Now, the biggest question I get from folks is, well, Josh, they should, I don't want to be, pushing students through who aren't doing the work of other students or who fail to meet basic needs. Don't. That's not what we're asking for. That's not what neurodivergent students need. They don't need to be coddled. They don't need to be pushed along through the system. They need adaptive assistance. And honestly, if someone cannot meet the appropriate standards of your organization, they're not going to be able to do so out in the real world. So how do we talk to folks about these different kinds of conversations? And when I say we, I mean you talking to them about seeing me. You do not need, if you have a good relationship, I'd encourage you to. But these are the kinds of conversations I have all the time. So it's not about asking to be just let through. It's about how do we create sustainable, long-term adaptations that will help your students be successful. Lastly, I'm going to say this again. You do not need to be the student's psychologist. You do not need to be the student's psychiatrist. You do not need to be their occupational therapist. Be you. You don't need to be anybody else. And if you need any of these other things, recommend that your student goes and seeks that help. So, tips and tricks. When giving feedback, be direct and timely. If you are concerned about whether a student is paying attention, because there are different ways that this can manifest, just ask. When it's appropriate, don't call people out in the middle of a meeting. After the meeting, hey, do you mind if I talk to you? Seemed like you were fidgeting with something. Just want to make sure you're understanding all the information that we're providing. Yes, I was. Thank you so much. That's my little fidget toy. Helps me stay engaged. If I don't have it, bet money on it. I have no idea what's going on. Don't be afraid to offer interpersonal feedback if you have discussed with this student beforehand. Hey, I saw how you were, such and such with this patient. Do you mind if I give you some feedback about how you may be perceived? You may have a student who is giving like just the hard, cold facts, a litany of information, and maybe forgetting to reinforce the empathetic human element. So providing some feedback as to how to word these kinds of conversations. If you're able to, help students apply interventions and adaptations to their current work environments. I give them these things, you help them mold them into into the application that you are in. If your student is struggling and it's out of your depth, encourage them to seek appropriate resources to meet their needs. If you don't know what those appropriate resources are, you can still send them my way, or a local psychologist or a local mental health professional. Typically us folks are pretty well integrated into these communities that can help navigate the different kinds of needs that students may have. All right, I am doing bad on time. So I'm going to walk through this with, I'm gonna walk through this, and then we have the other vignette that I covered in the previous presentation. If you have questions, start tossing them down into the chat. I want to make sure that I have a little bit of time at the end to answer any questions, and I don't want to butt up into Dr. Withrow's presentation. So I'm going to start going in. So let's set the stage. So Lena is a third-year dietetics student who is neurodivergent. She begins her clinical rotation at the local hospital. She's eager to learn, but feels overwhelmed by the new environment, the sensory input, the bright fluorescent lights, the noise of the bustling halls, and even the smell of the food in the cafeteria feels overwhelming. Her preceptor, Maria, welcomes Lena and introduces her to the day's activities. Today, we'll observe a nutrition assessment with Dr. Singh. Afterward, you'll start getting familiar with patient charts and dietary plans. Lena nods, but her anxiety begins to build as she worries about keeping up with the fast pace and the sensory distractions around her. As part of Maria's orientation to the hospital, she implements the open strategy, encouraging Lena to lean on her for support, which gives Lena the opportunity to disclose her neurodivergent identity to Maria and share her sensory difficulties. Next, so this is kind of setting the stage. Next, recognizing the struggle. As Lena shadows Dr. Singh, the rapid flow of information starts to feel like too much. The patient's dietary history is discussed quickly, and Lena struggles to keep track of key details. Her mind begins to wander as the noise and the bright lights make it difficult to focus. Dr. Singh asks Lena a question about the patient's meal preferences. Lena, unsure and overwhelmed, hesitates. I'm not sure, she responds, feeling self-conscious about not having the answer. Maria, noticing Lena's discomfort, intervenes gently. Hey, let's pause for a moment and go over the patient's chart. Lena, would it be helpful if we reviewed the key points together? So again, this is a perfect example of recognizing what's going on and offering immediate support and non-judgmental intervention. Let's take a beat. Let's review. Now, I understand this is not going to be applicable perfectly one-to-one to all of you, to all of the situations you encounter, and maybe even specifically to your organizations. Many hospitals are very fast-paced, are very high density, and have a lot going on all at once. So this is very much an ideal situation. Oops. Next, adapting the approach. You have set the scene, you know what her struggles are, you have seen it in place. So, after the assessment, Maria takes a moment to check in with Lena. I can see that the fast pace and noise might be making it hard for you to concentrate. Let's try something different today. How about we use a checklist to break down the tasks? This might help you stay focused and organized. And if the noise is too much, you can use noise-canceling headphones while reviewing patient charts. Awesome. Beautiful intervention. And if you notice, directly after the assessment, we are still in such a discrete window of time. Maria first checks in. Hey, let's navigate this immediate situation without calling Lena out. Cool, that situation is done. All right, let's round up. Let's figure it out. Let's make some adjustments. Immediately, Lena's face lights up with relief. Yes. Oh, that would be really helpful. I've always found checklists help me stay on track. Maria continues. Take your time. If you need extra time for processing, just let me know. There's no rush. Now, you may suggest these things to folks and they may say, no, that doesn't work, or I don't have my headphones with me today, or whatever. It's okay to say what works for you. What do you think might be helpful? And if they say something that's maybe not in line with policy, or you just having years of knowledge, know that that's going to be really difficult to implement, that's okay. Try to work it with them. Be experimental. And if you don't know, you also don't have to know. You don't have to have things right off the top of your head. You can just simply say, hey, I noticed that was kind of tough for you. Let's walk it through. What feels like a way that we can make this maybe a little more easy, that I can support you a little more, or even just, hey, was that okay the way that I intervened there? How did that feel for you? All great ways to intervene. Next, finally, I guess I should say, the next day, Lena is equipped with a checklist and noise-canceling headphones. She feels more in control as she works through the tasks. With the checklist to guide her, Lena can focus on one task at a time. While the environment is still busy, the adjustments allow her to concentrate better and feel less overwhelmed. Maria checks in at the end of the day. How did it go today, Lena? Beautiful. Excellent. You want to make sure when you're putting these systems in place that you are checking in. I know this is extra work, but it pays off. Making sure that the implementation is successful and actually is adaptive. Lena smiles. I feel a lot better. The checklist really helped me stay organized, and the headphones made it easier to focus. I feel more confident moving forward. Wonderful. Don't hesitate to reach out to me if you have any other difficulties, Maria says. Again, we want to reinforce that I am someone who cares. Tell me if you need help. I'm checking in with you to reinforce that. I'm letting you know to reinforce that. We really, I know this may sound ridiculous. Like, Josh, do I really need? No, you don't need to. But I have never had a client come to me and say, oh my God, I have this horrible supervisor. They won't shut up about how much they care about me or how they're willing to help me in any situation. No, never, not a single time. So points to highlight. Using the open strategy allows Lena to disclose her struggles. Using a checklist, using adaptive skills can help provide her with clear structure for complex multi-step tasks. Providing accommodations for sensory needs allows students to perform at their best. She can actually sit down, put her headphones on, and focus at the task at hand rather than getting behind. Providing flexibility around time and deadlines, again, when available, can alleviate unnecessary stress. Now, again, this is not a situation where I'm encouraging you to break rules, where I am encouraging you to violate policy. Within your boundaries, and you understand your organization's boundaries. Finally, encouraging self-advocacy to reinforce your open model and give your student reassurance that you are here to facilitate their success. Now I'm going to make an executive decision. I have a vignette. It's a long vignette. If we try and do it right now, we're not going to get through it. This vignette was also a part of the first presentation that I put together. We go through it, we talk about it. I'm probably just as rushed during that one because time management, who is she? Don't know her. But I would love to, if anybody has any questions at all about neurodivergence, about me, about any of the vignettes, about something that is barely tangentially related, but has something to do with neurodivergence, please throw them down in the chat. I would love to spend the next 5 minutes just answering anything and everything that y'all have for me.
Thank you so much, Dr. Bach. As we have questions hopefully come through the chat, I do have one, particularly in regard to the scenario you just described. I think it's great to say, when there really isn't a rush, to allow people the time that they need to review the chart and that kind of thing. But I'm wondering if it's a situation in which, let's say, like an order is due, like for parental nutrition, or if we are at a school pushing out lunches and we need to have trays prepared. Is it best to say up front, okay, so here is the timeline that we need this to be done by. If you feel that you can't meet this, please let me know so I can assist. Or how would you do that in situations where there might be a rush?
Totally. No, I think that is such a wonderful question, Brianna, and I really appreciate you asking it. I think the best thing that you can do is set expectations for yourself and for your student. If you are in a facility or in an organization where there is time crunch, where it is impossible to provide that additional space and or time, communicating that early, and not just to the, if you have multiple students, I would encourage you to just communicate this broadly. I think one of the other things that is important is not accidentally othering your neurodivergent folks by always speaking to them when you are discussing these kinds of expectations. Now, I think it's appropriate to pull them aside if you if you think they may particularly struggle. But I think having a contingency plan, saying, hey, here's what we are going to expect. You have mentioned to me that X and Y and Z can be difficult for you. Let's have a contingency plan. If you are feeling overwhelmed, overloaded, and you cannot manage, I want us to be able to have a good expectation of what that looks like, how you can communicate that to me, and what I can do to support you in that situation. I think the ultimate kind of just knowledge is that at the end of the day, this is on whatever, whomever preceptor. And I think that if you need to step in and take over process, obviously that's not preferable, and you would want to definitely circle back with the student to ensure that that doesn't happen again. But ultimately, you are the safety net, and you're going to be able to help guide this student through. And you know what? You may find that this high intensity, inflexible rotation is not going to be the best fit for this student. But I think having those kinds of open and honest dialogues about expectations and exit plans is going to give you the best opportunity to be successful. I've seen a couple questions come through. Absolutely, Linnea, it's my pleasure. How trauma-informed approach can intersect. Oh my gosh. Uh, Trauma-informed. I could talk for a whole nother hour. I think that.
So to repeat the question for those of us watching the
Yes, sorry.
video
I apologize.
later, thank you.
Yes, Lena asked, I wonder how a trauma-informed approach can intersect with what you're sharing. I think that, there is a lot of trauma in being neurodivergent, both capital T and lowercase t, explicit and implicit. And I think that, simply understanding the broad strokes of a neurodivergent experience can help you show up in a more trauma-informed way, using appropriate language, being curious, not making assumptions. All of these things are ways that you can show up trauma-informed for the students that you're working with. And again, I think that making sure to just stay open, because we all make mistakes. A lot trauma informed does not mean trauma all knowing. So being open to being fallible, being open to being corrected, being open to learning is a great way to show up in a trauma informed way. And I've often found that neurodivergent folks are much more accepting, much more gracious in the ways that they deal with these kinds of situations if you show up authentically, honestly, and willing to admit when you have faulted. And that's a great question. Psychology Today would be the perfect way to do that. I'm going to jump to Sharon, and that'll be, I think, probably the last question, just because I don't want to bump into Dr. Withrow too much. I've often wondered how best to alert preceptors that an intern is neurodivergent and may have accommodations. I've asked students to advocate for themselves directly with a preceptor, since one, they know what their best needs are, and two, I don't think I can disclose their personal information. You cannot. Very good thought. We have learned the hard way that not telling preceptors this in advance can backfire. Preceptors were angry with us for not preparing them properly. So first and foremost, you are not allowed to disclose personal health information of a student. Period. Point blank. That is HIPAA. That is a federal law. You're not allowed to do that. However, this is a great learning opportunity for the student. It doesn't matter how your neurodivergence shows up, it's going to show up. And it is important, although admittedly unfair at times, it is important for students to learn how to properly understand their accommodations and how to properly convey their accommodations. Now, again, it's pretty crummy that you have to always out yourself to people in positions of power. That sucks, but it's largely unavoidable. So if you provide an environment to talk with students, provide opportunities to encourage them, provide ways in which they can safely disclose these things, then it's up to the student, because ultimately you're not going to be there with them when they're out of their educational setting to do this work. So it's uncomfortable. It sucks. It's pretty unfair in a lot of ways, and it's a part of our world. And leaning into that to help teach these students how to show up and how to disclose in a way that protects them and also provides appropriate context is always going to be the best route that you can take. Yes, beautiful, Lisa, spectacular. But yeah, at the end of the day, your goal as the institution is to provide the space for the intern, and the intern's goal as the person with neurodivergence, or pardon me, the intern's responsibility as the person with neurodivergence is to disclose in a way that is going to benefit them. Now, helping them learn how to do that is a whole other task. And if you feel ill-equipped to do that, encouraging them to seek therapeutic assistance, encouraging them to do all kinds of stuff like that. But yes, your role is to provide the space, just as Lisa kind of named. I'm not going to take too much more of Dr. Withrow's time. Thank you all so very much for not only having me once, but having me twice. Such an honor and such a privilege to be able to present in front of you all. I have listed my email and my website. If you have any questions, comments, concerns, would like to consult, please reach out. I am happy to do this. This is a huge passion of mine. I love working with neurodivergent folks. I hope you all have a wonderful rest of your day. I'm going to go ahead and unshare my screen so I can give power back to Brianna. I think. Did I do it? No, I
Nope,
didn't.
you did not.
I just closed out of it. There we go.
Thank you so much, Dr. Bach. It is such a pleasure, and we wish we had hours more with you, but we appreciate your time and hope you have a lovely rest of your day. All right, so with that, it is my pleasure to introduce our next speaker, Dr. Nikki Withrow. Her name may be familiar to you for multiple reasons, one of those being that she was the DI and MSDI director here at UNCO for many years. So she no longer serves as our director, but she has since moved to another position. But she maintains involvement in our programs, and we are so grateful to have her at UNCO and to have her here today. Dr. Withrow is now the Director of Evidence Generation and Clinical Research at Kate Farms. And in addition to her roles in directing and research, she was also a clinical dietitian at the Children's Hospital of Colorado for over 20 years. So specific to autism spectrum disorder, Dr. Withrow has performed research including how gluten and casein-free diets are used in children with ASD, iron status, GI symptoms, picky eating in ASD, and Dr. Withrow developed the SAMI, which was the first screening inventory to screen nutrition risk in children with ASD based on the 4 domains that impact eating in these kiddos. And if we're lucky, maybe we'll get a peek at that today. But if I were to list all of her experience, qualifications, publications, we would probably exceed our time allotment together. So I am going to leave it at that. Dr. Withrow, would you please share your screen and take the floor?
Thank you, Brianna. Hold on one second.
Sure.
Okay, what screen can you see?
We can't see any screens right now.
Phooey. Oh my goodness, I knew this was going to happen. Okay,
There we go.
no. Sorry, everyone. I'm horrible at technology.
Okay, take your time.
Okay, so I'm trying. What about now?
So we are seeing the presentation, the PowerPoint. If you, yeah, go ahead and share it as a slideshow.
Okay, I just click. Okay.
There we go. So we're seeing your presentation now without your speaker notes.
Okay, good. Then I'm doing really well. So I'm so excited to be here today and following Dr. Josh Bach's presentation. I think mine is more of his phase one, where I'll be going over some information about being a clinician over 20 plus years at Colorado Children's Hospital, having legacy research projects still there, and then actively conducting research in autism. I still sit on a couple different medical research boards across our country, one being a residential facility and the other one being on a New York State grant outside of my work at Kate Farms now. And then during my doctoral work, I actually was a pre-doc fellow at JFK Partners at UC Health Medical School, where I was a fellow in leadership in educational training and neurodevelopmental disorders. So it's a national training grant for neurodevelopment. And so I was a pre and a postdoc fellow there for over 5 years. So I really honed in on autism. And today I'll primarily speak about autism. I know Dr. Bach talked about neurodivergence, and I primarily worked at and still do with kiddos with autism, but we'll also talk about Zoe. I am seeing so many of past graduates, and I'm loving it. And also preceptors. So I'm so excited to see all you guys. But so today I'm just going to talk about, let me progress with the slides. Some objectives would be to better understand common medical conditions that impact eating in ASD. And I want to say a lot of these medical conditions can be applied to neurodiverse individuals. But again, I am primarily concentrating on ASD. Second objective, to better understand food selectivity in children with ASD, to better understand nutritional concerns, and to be able to discuss common treatment approaches. So let's begin. And so I think that's really important to understand that in autism and in neurodiverse individuals and kids, that there are common medical conditions that can impact eating in ASD. So along with those core deficits that Dr. Bach talked about briefly about ASD, more often than not, individuals have co-occurring diagnoses. And the ones in particular that I focus on are problematic eating behaviors in clinic. I did start a feeding clinic at Colorado Children's Hospital several years ago and focused primarily on autism, but I did have other medical conditions in there as well. But again, autism. So I focus on problematic eating behaviors. I really looked at how generalized anxiety could affect eating. I saw a lot of kiddos with GI issues, sleep problems, the core deficits of autism impacting how they eat. And so four that really come to mind and that are supported in evidence and often seen in clinic and in residential facilities is that of GI dysfunction. So of the co-occurring symptoms, kiddos and individuals are 8 times more likely to suffer from one or more chronic GI problem when we compare them to the neurotypical kid and individual. So this is when I first started a couple decades ago, we didn't have a lot of literature, but now this is pretty substantiated and some solid literature to say that we're really seeing GI dysfunction in kiddos with autism. And one of the most common symptoms that I see anecdotally, and again supported in some of the literature, is constipation. So that's the most frequently reported GI condition. And then secondly, we see a lot of loose stools. So, but constipation is usually the #1 complaint that I would see in clinic and in the literature. In addition to constipation, loose stools, we also have, and this is so cool, this is why I love our field, everybody, preceptors, postgrads, clinicians, is that we are getting more and more research in autism in understanding the gut microbiome. And so, and this is exciting because 10 years ago, I couldn't, Gina, one of our extraordinary preceptors who's on this call I saw, we talked a lot about autism at one point in time, and we didn't have research on microbiome when I talked to her several years ago. And but now we do. We now know that microbiome. Now, what we don't know is the why, but what we do know is we're seeing different microbiota in individuals with autism. And as we know, some bacteria in our guts affect our immune system. As dietitians and students and interns, we know that it affects our moods. And so we've seen a different type of bacterium in children and adults in autism that is specifically tied to moods. So think about that. We're really going to know how to truly impact these kiddos and individuals' guts pretty soon with different probiotics, prebiotics, and individualizing our care. I just think it's so cool. And so what a lot of physicians have said to me is, you know, Nikki, I think the microbiota is really compromised in ASD because they have so many infections. And any of you guys know what we commonly treat ear infections with? Anybody want to say? And Brianna knows I'm probably not going to be looking at my chat.
I will let you know, Dr. Withrow.
Okay, thanks. So ear infections are still commonly treated with antibiotics. And we know as dietitians, students, interns to be dietitians, that an antibiotic really can impact our microbiome, right? And it flattens it out sometimes. And so that can cause loose stools and sometimes slow down that peristalsis and GI motility and cause constipation. So we're really wanting to see if we could decrease even antibiotic use in children with autism with more and more research. So it's really exciting stuff. We also know that sleep disorders, greater than half of children with ASD have one or more chronic sleep problem. 5 years ago, we didn't really know the why. I tied it to dietary intake, but now we have genetic studies that show that individuals with ASD are twice as likely to have mutations in genes that assist in regulating sleep. So what Brianna didn't tell you is that I also have a son with autism. He was my impetus 2 decades ago to switch fields in clinical dietetics, to learn and become an expert in autism and feeding and all that encompasses dietary intake. And my son had a horrible sleep disorder. Therefore, his mother had a sleep disorder for probably different reasons, obviously. But back then, 20 years ago, I tied my son's sleep disorder, I correlated adult literature to restless leg syndrome, because what I witnessed when I'd be on the floor at night in my son's room is a lot of thrashing and moving around. And so then I thought, is this restless leg syndrome? And as dietitians and students and interns, we know that restless leg syndrome is correlated to low iron stores. So at Colorado Children's Hospital, I went in with the adult literature, and then we put together a multi-site study nationwide through CDC to look at even iron stores in children. What we found is that they were lower than in typically developing children. And when we started repleting iron through drops, we saw some of those restless leg thrashing, getting up a lot, calm down. Now, did it solve all sleep issues? No, but it certainly assisted in a lot of improvements in getting kiddos to sleep. So we also, looked at, as a dietitian, I would look at if they have a sleep disorder, and I did food recalls, food 3-day food records, and also biomarkers. Their iron studies looked good. Then I went and thought, okay, maybe they're consuming enough, but maybe they're not absorbing it. Let's go back and look at their vitamin C. So as a dietitian, going back and really thinking about, okay, how do we absorb iron? How can we enhance that absorption? Again, something that a dietitian's role is when you see an individual with unique needs and kiddos with sleep disorders, to really look at their dietary intake. Another one that we are studying a lot about are food allergies. So right now, I'm involved in a EOE study, because at Colorado Children's Hospital, we were seeing so much trouble with just swallowing. And back in the day, 10 years ago, we really didn't even know EOE existed in neurodiverse patients and kiddos with autism. We now are looking at that. We're studying EOE. We're seeing that it's more prevalent in kids that are struggling to eat. And so that's exciting. Another area of research that is booming are food allergies and food sensitivities. We see that some of these individuals aren't coming back positive for food allergies, but we are visibly seeing reactions and sensitivities to so many foods. And so we're taking those sensitivities as important as allergies. And again, 15 years ago, when I would say to physicians, I'm really seeing sensitivities, I know they're not coming up as allergies, but let me tell you how now physicians all over the country are really looking at sensitivities, even if they're not coming up as allergies. And then another area that is something that as a dietitian, we should be really focusing on that impacts eating is the risk of obesity, because we now have evidence showing that children with ASD are more likely to have higher rates of obesity in childhood. So starting pretty young. And there was a study that was done through the Autism Speaks Autism Treatment Network, which I helped bring to Colorado many years ago at Colorado Children's Hospital. And we compared NHANES data to our treatment network data. And we did see that children with ASD were at a higher BMI and higher risk of obesity, again, at such a young age. So we're seeing in large case control studies exploring metabolic complications in ASD. And unfortunately, we're still seeing more risks of obesity. Again, we don't really know the why behind it. We can speculate that possibly it's the types of foods they're eating, or in ASD, the lack of physical activity, combination of both, genes, environmental. And so, but we are getting and looking at more research. So there is again, not a ton of research, but we are getting more about diabetes, and it shows that adults with intellectual, so neurodiverse individuals, especially autism, we're seeing 3 times more likely to develop diabetes than the general population. We're seeing that even at a younger age group as well. So there's general agreement within the research literature that the predominant nature of kind of those problematic eating behaviors is that of food selectivity in autism. I don't know if Dr. Bach said anything about the founder of autism, but his name was Dr. Leo Kanner. In 1940, he identified the first cases of autism. And interestingly enough, he included problematic eating as a defining feature of autism. Now, since 1940, it's gone, back and forth all over the place. But I want to say that to have that be a defining feature and to be a dietitian and still struggle to get healthcare providers, school districts to really support our kiddos in feeding them is just kind of dumbfounding to me, since it's been around since 1940 as a defining factor. So today we know through research that up to 90% of children and adolescents with an ASD are reported to have some type of an atypical eating feature behavior. And when compared to typically developing children, to up to about 35%. So significantly different still. And food selectivity can be characterized as a diet that is limited in a variety. Sorry, guys. Limited in variety of foods, and often they reject novel foods. So that's kind of a defining factor too. So the 3 domains that I'm really going to focus on today are sensory processing, and you heard Dr. Bach talk about sensory processing, motor impairments, and just the core deficits alone that can impact eating in individuals with autism. So the first one in food selectivity is something that Dr. Bach briefly mentioned, is sensory processing, impairments. Some people say it's sensory processing disorder, challenges, but the research shows anywhere, and I want to stress, because you guys heard Brianna say that I am very much into research, that why there's such large ranges in these percentages is that there's not a great way to study these variables of interest yet. They're not a consistent way to even define sensory processing in ASD. So you'll see a range from, they can affect up 30 to 100% of children with ASD that experience some type of a sensory processing condition issue. So researchers began really diving into sensory processing and autism in the 1970s. And what we do know is that in neurodiverse individuals, and gifted and talented, in people that have ADHD, ADD, Fragile X, there is an increased prevalence of sensory processing. So as a dietitian, when we work with individuals and they say, oh my goodness, I stay away because of smells or textures or the feel of foods, or if I hear something that I don't like about a food, the crunch of it, the cooking of it, probably should clue you in that they might have some sensory factors that are impacting what they eat and causing a little bit more food selectivity. So some researchers think that sensory processing issues may be the #1 reason that cause nutritional risk in individuals. So what I have seen in clinic for 20+ years, volunteering in the community still with parents at Autism Society, in different groups in Denver, is that so many individuals experience multiple, so not just one. So being that they avoid certain colors of food. Has anybody worked with individuals that have sensory processing issues and possibly avoid certain colors of food, and what challenges that individual has if they do avoid certain colors of food? Or what are the common foods that would be avoided if they avoid foods other than white or brown?
I will jump in here. I would say I haven't experienced this with clients or patients, but I can assume, or actually I probably have, but I think we can all say nutrient deficiencies will occur if they're just eating one color of food. And we did have someone comment avoids most vegetables.
Yes. So a lot of colorful foods are avoided. And so as a dietitian, we think about, those micronutrients that they could be getting low in if they're not taking supplements or eating fortified foods. Very sensitive to light. I've worked with kiddos that have to eat in the basement where there's no natural light. Eventually working with behavioralists to work on bringing them up slowly. As a dietitian, I can honestly say I've never worked in isolation in any of the kiddos that I've worked with. I've always worked with like Dr. Bach for psych, with OT, with speech, with PT. And so with some of these sensory things, OT will come in and complement what is needed to work on. And then I look at the dietary risk, and then I start working on, expanding their diet. So temperatures, I've worked with tons of kiddos that avoid hot or very cold. I've also worked with kiddos that avoid certain smells of food. So meat is a big one that they avoid. And so just brands, believe it or not, brands are a huge one. And kids that avoid certain, they will only eat certain brands, let's say General Mills Cheerios, and if mom and dad or caregiver buy a generic, they won't eat it. And so there's certain ways that we'll talk about in the next couple slides, and how to work with OT and speech to complement their therapies in expanding their food repertoire, and how a dietitian can do it with them. So another is motor impairment. So again, depending on the research, it can affect up to 100% of kiddos with motor impairments, and really thinking about gross and fine motor. Can anybody tell me how they would think fine motor would be an impairment if a kiddo was kind of suffering with a fine motor impairment? How it would impact eating? You guys are quiet, especially my previous interns.
It takes a little while, I think, for people to type into the chat. But one thing that comes to mind would be using utensils.
Yeah, so just picking up a utensil and getting food on that and bringing it to your mouth successfully, it's really difficult. And so absolutely, that is a hard thing to do. When kiddos are suffering with oral motor impairments, this could be that they have a weak suck. They have poor lip closure, so liquids, drain out of their mouths. They can't pucker their lips. They don't blow bubbles, which kind of helps with all that oral motor control. Again, that's when OT comes in and really complements the work of a dietitian. The dietitian focuses on the foods, the liquids, and what to make everything that goes in that kiddo's mouth more bang for their buck. But then they really work very closely with an OT. How do you think gross motor skills would be impacted?
There were some comments about oral motor challenges can occur with chewing, and as mentioned, swallowing, and then crossing the midline is challenging, Linnea says.
All of those, that's all great input. Thank you for putting those in the chart or chat, and Brianna, you reading them. So gross motor, what I'd see in clinic quite a bit are primary caregivers coming in and they're saying, Dr. Withrow, we see Johnny and he's just running all around, he has so much energy. He's just such a runner. He walks all the time, he runs. And I would then put him on an exercise ball at a little table and have him scoot up where he wasn't leaning against the back of it, and see how long he could engage his core. And oftentimes what I would notice is that kiddos would fold over quite quickly. And can we eat like that? No. And so then I would know, okay, PT needs to get involved. We need to really strengthen this little kiddo's core strength, neck strength, core strength, so they can actually sit and enjoy a meal. But until they have that core strength, then we need to put them in a chair that provides that support. oftentimes parents will report, oh my goodness, Johnny did so much better when we put him in a chair that supported him. And he was able to sit longer than 2 minutes without really getting upset about sitting. And so I always think about, as a dietitian, if their oral motor is okay, make sure I better understand when parents say he has a he has a different time or a difficult time sitting at the table, to look at that core strength, to look at their head and neck control. Like Dr. Bach said, oftentimes developmentally, they are a little bit delayed. And so I always take that into factor as well, that they could be just a little bit delayed. They're going to get there, but I need to meet that child where they are, and then also provide education to the parents on, okay, they can maybe run a ton, but we need to build up their core strength. And OT, PT comes in and helps them with that. So another area is truly the core deficits of ASD. So when we think about the core deficits of ASD, we're thinking about rigidity, the need for things to be the same, the kind of inflexible, repetitiveness. And so when I think about those core things that impact children with ASD, I think about how they translate into mealtime behaviors. So one thing that I can honestly say, feeding hundreds of kids at Children's, but I have to take this back to my son, who I struggled to feed pretty much every day for a long period of time, where I didn't always clue in to those core deficits, where if I put food on a new plate and he didn't recognize it, sometimes it would elicit those maladaptive behaviors of him throwing it at me, kicking it, throwing the food. At times, self-injurious behaviors occur with kiddos. They start biting themselves, pulling their hair, just because they don't see something familiar. And so I want to make sure that I always go back to that, because even though they might have some sensory, they have some oral motor or gross motor, the core deficits can really impact how they eat, what they eat, and their food selectivity. And so that takes time with, let's say, Dr. Bach working on behaviors and really expanding their comfort of even seeing a new dish in front of them, not putting any food on it for a long time, but just being comfortable seeing another dish or a cup or a feeding utensil. Might take several exposures for a kiddo to feel comfortable eating. And but I think it's really important to really understand that those things the core deficits can really impact how somebody's feeding and eating. I put this on as kind of showing the difference between picky eaters and selective eaters. I'm more than happy to give you my slides. But one thing that I want to point out is we know, by being parents, by working with kids in school districts or at WIC, children's hospitals, that picky eaters are really common, right? The research, I think, is over 50% of kiddos are picky eaters. But what is a little different with it is that food selective kids really are more long-standing. They sometimes don't outgrow the food selectivity like picky eaters. We tend to get them to outgrow them. And then they have more of a food repertoire or variety of foods when compared to food selective kiddos. So, yeah, so there are some big differences. And I think as a clinician, to understand those and to kind of put those in the back of your mind and say, okay, are we looking at this kiddo? Is he more of that picky eater? Or is he more food selective? And if he's more food selective, we know we need to kind of attack some feeding treatments, because if we don't, by the age of 8, research shows they've really settled into their feeding styles and what they want. And it's harder. It's not impossible, because I work with a lot of kids that we got to expand their food repertoire and they eat, everything under the sun. But it takes longer. So nutritional concerns for kiddos with ASD, or anybody for that matter who are a little more food selective. Macronutrients used to not be really on our radar, but it is now. What we're seeing because of more obesity and overweight kids is more saturated fat intake, less of the polys and monos, and more of trans fats. We're also seeing less quality protein. And so I think this is important to mention, even though years ago we had hundreds and hundreds of food records and we didn't see macronutrient differences until pretty much the last 5 years in research. We're seeing still micronutrient insufficiencies and deficiencies: vitamin C, vitamin D, calcium, heme iron, iron. I want to point out that about close to 10 years ago, we saw Boston Children's Hospital. I was actually there, and I was meeting with the physicians, and they found 6 cases of scurvy in kiddos with food selectivity. And the one common characteristic was long-term chronic food selectivity. So not just picky eaters, it was the long-term feeders. And a study that was done by William Sharp and colleagues at the Marcus Autism Center, I did a study with them as well years ago in 2015, showed that these kiddos have a lot of micronutrient deficiencies, far more than what I listed here, that vitamin A, C, D, B6, B12, E, K, are all micronutrients of concern. Again, being a dietitian, going back to their food records, going back to 24-hour food recalls, you'll be able to really hone in on what feeding types of interventions the kiddo needs. And then another nutritional concern is just how people are treating autism. So as a dietitian, I would see a lot of families come in and say, wow, my chiropractor put my son on a FODMAP diet. There's been no supervision. He's been on it now for a year, and I'm finding that he's getting more weak, his blah, blah, his skin, everything. And we know as dietitians, that's not a long-standing diet. You do it in shorter increments. You can go back to them if you need to. But so as a dietitian, I would see a lot of nutrient deficiencies or risk of nutrition deficiencies in the dietary interventions alone. The most common one is the GFCF. And oftentimes that would be one that I would prescribe for patients, but I wouldn't do it together if I didn't think it was needed. So for example, if a kiddo came in with more GI issues, constipation, loose stools, I might just start with the casein-free diet. We know that antigen is roughly out of somebody's body within 3 to 4 weeks. So I would take that out and see if their GI symptoms improved. Like Dr. Bach said about self-stimulatory behaviors, if I would see flapping, walking on toes, peripheral side looking is one self-stimulatory behavior. If you ever see an adult who you're working with as a student, an intern, or any of your clients' patients, if they're looking out of their peripheral, that's a characteristic of autism alone as a self-stim. Other self-stim behaviors aren't, but that is. So if I see a lot of self-stimulatory behaviors, I then might recommend a GF diet and see if those can be reduced, because anecdotally speaking, we see a lot of reduction and improvements in self-stimulatory behaviors off of gluten. And that research is interesting. It came out of schizophrenia back in, I think, the 1940s, where it was first seen to, if somebody went off of gluten, that their moods increased and symptoms improved, I meant. So I do use gluten-free, casein-free, but we also know that some of these diets, ketogenic, some kids with autism suffer with more seizures. And so ketogenic has become very popular. I haven't seen it reduce keto or seizures in kids with autism. Years ago in the 90s, when I worked at Colorado Children's, I was one of the dietitians for ketogenic diets for seizure disorders. I did then see it work, but not as much in autism yet. Specific carbohydrate diets. So all of these diets, as nutrition experts in this session, we know can impact nutritional risk, because we're eliminating so many yummy foods and nutrients. So as a dietitian, I am not one to tell a mom, diet or dad, caregiver, you can't do this, because usually if I did ever say that, I'd never see him again. What I would strongly encourage is how to monitor risk, nutritional risk, how to maybe implement these diets in a very controlled, monitored way that dietitians can do for them, and not let them just go out on their own and do a FODMAP diet without being monitored. So I tend to do a lot of education and a lot of education about potential risks, and quite frankly, telling them that we don't have a ton of evidence to support them. And I do tell them what we do have, because then they can make up their own minds. So treatments, I know we're running out of time. I feel like Dr. Bach, phase 1, that he did a lot of the education piece. But really, it's what we do as dietitians, and do it so incredibly well. We screen, and in this field of neurodivergence and autism, again, I created a screening tool that's validated, being used in several children's hospitals around our country. We even have it abroad in Europe being used. It's being used for research now and in residential facilities. So I have 2 different forms of it. If any of you guys are interested in it, just email me and I'll send you either a community, clinical, or a residential copy. But it basically, what it's designed to do is to do a quick referral, because that's what parents are struggling with, is who can help Johnny eat. Dietitians, we know we can do that. We can help with dietary intake, warding off those nutritional risks. But we also know, like Dr. Bach said, let's stay in our lane. We need to refer if this kiddo has a lot of sensory processing. The instrument will do a quick referral to an OT or to a speech and language. Behaviorally, those core deficits and having those aberrant mealtime behaviors, quick referral to a psychologist, a social worker to really work on behavioral interventions while the dietitian is working on dietary intake. So I always do the NCP process, come up with intervention, a monitoring plan. I individualize everybody's care because everybody deserves it and everybody is so darn different. And then I put food chaining is one technique that I use. And a lot of behavioralists have told me they use preferred versus non-preferred. And so I can talk about a little bit more about food chaining and preferred and non-preferred if you guys would like, or we could just the last 10 minutes take questions or talk through a case study. And I can't believe it, Brianna, but my batteries, I don't know how long I have left with this battery and my power cords.
Okay.
So if I accidentally exit, I really apologize, but do you want me to stop sharing my screen and we could talk through a case study, or do you guys just want to ask some questions?
Why don't we begin the case study, and then if questions come in, we can adjust them as they come.
Sure. So this is a lot of what I would see, it kind of typical at first. The 6-year-old male, as you guys know, autism affects males 4 times more likely than in females. The rate of autism, so you guys are you're going to be working with somebody with autism, is 1 in 36 individuals in this country. I just read a statistic that it could be changing to 1 in 28. So again, working with your interns, working with your students, working with your clients and patients is so important to even just know basics about autism. So diagnosed with food selectivity, BMI 95 percentile, and chronic constipation. 5 top foods: chicken nuggets, plain white bread, French fries, cheddar cheese, and gummies. And has a difficult time sitting for more than 2 minutes, prefers to eat in front of a distraction, so often TVs or iPads or Kindles, or is when and how I can get kids to eat. Think about that as a mom. When you're telling me to feed my son in front of a distraction, but I had to really learn that that was the only way my son, Sam, would eat. And then I would depend on a behavioralist to come in my home and fade those prompts. And so if parents serve a non-preferred food, Eric becomes self-injurious. So that's the case. And let's just talk about it. So a lot going on there, and a lot that dietitians probably can't address right away and need support. But anybody have some suggestions on what they would focus on, or any questions on how I would address? That's a lot, right? In an outpatient clinic appointment to figure out how to address and what to address. And for entry-level dietitians, I know we have some recent grads who are working in peds because I've written your recommendations and you got the job. So bravo to you guys. But where to start and how to start it? Can anybody tell me?
Well, there was one question that's relevant to, I think, this case. And the question is, could you describe how to use food chaining to increase number of foods accepted?
Yeah, so I'm going to be quite honest with you. That's one method that I find that works better for me and parents when I'm working with them, but behavioralists like sometimes the preferred, non-preferred. So let's take French fries. If I knew Eric had some sensory stuff going on and he only ate McDonald's French fries, shoestrings, I would get the shoestrings. I'd meet the child where they are. I'd get a bag of frozen shoestring French fries, and I would probably bake a couple, and then I put them with I usually don't start by touching them to see if a kiddo would mind if I mixed them, but side by side or even on a different plate. So they got used to seeing same but different would be a lot of my wording. It's same, it's a French fry, looks different, but same because it's a French fry. And then once I accepted that shoestring, I might change the shape of another French fry. If shapes didn't seem to be what they avoided, I would then change on how it's cooked. I would bake it. I would then make potatoes, fresh potatoes, into shoestring fries, and I would bake those. And then I would build into, let's say the goal of the parent would be a baked potato, but then I would do bigger wedges. And so it just takes time, and you don't change every sensory component of a food. You really pick, what it is. If a kiddo avoids colored foods, and parents wanted a different type of a chicken nugget, and this kiddo is only eating McDonald's chicken nuggets, which I saw all the time, again, I do the same thing. I would start by buying a bag of frozen, maybe plopping one next to them, bringing it closer once they visually tolerate it. Let them touch it, feel it, smell it, engage their senses in it, and then build, the healthier chicken nugget, then bread a chicken breast, cut it into pieces. So it's just all these little steps. Research shows that neurotypical kids typically accept foods, novel foods, within 25 exposures. Kids that I worked with would take 50 plus. And I'm saying that too because my son was one of them. And so think about how exhausting that can be for a parent to do that with every type of food. But I want to reassure everybody tonight that once kids really get into this habit, it starts going a lot faster. If the parents, caregivers are consistent, I have found that then building different types of bread into a child's diet goes faster once they trust the process, trust the counselor or behavioralist, trust anybody who's working with them that they're not going to make them eat huge amounts of food, and also different foods, like completely out of the ball game. So food chaining for me is something that has really worked. Hopefully that answered your question.
We don't have any other questions for the time being.
Well, phooey.
We did have Linnea shared her experience with food chaining. One thing that Linnea said is an example of strawberry gummies to dried strawberries to fresh strawberries, etc., just as you explained, Dr. Withrow. And then one thing that's helped us is to have a separate bowl in which one new food is a tiny portion, and that's called their exploration bowl. And then there is a whole hierarchy of exploration based on SOS model, and one step could just be to touch it.
Yeah, touch it, feel it, smell it. I would do picnics on floors and feed toys. So the expectation of that child eating a new food wasn't there. And so just getting comfortable seeing a food, feeding baby dolls or Legos or whatever it is. I know it sometimes can be really hard for adults to say, I don't want Johnny to play with their foods, but sometimes engaging those senses, getting their hands a little dirty and faces actually benefits them, and then they start eating it and trusting that food. So I always have to work slowly with parents, because feeding a child is, it's one of the most intimate things a parent can do. And when you can't feed your child successfully, it is extremely tough, and I've been there. So empathy is a huge factor in any of the kids and adults that I work with. So,
Thank you, Dr.
like I said earlier, I think I put my email on the last slide, which I stopped sharing. But if you want to get in touch with me, Brianna knows both of my emails. Again, I'm full-time at Kate Farms, teaching still at the university, but check 24/7 Kate Farms, and probably.
Okay, I think we lost you there, Dr. Withrow, but
Good.
okay, no worries. Thank you all. That concludes our presentation. You have Paris's email and you have mine. And we appreciate your time, and please reach out if you have questions and to receive that certificate. I'll stop the recording and I'll hang out in case anyone has questions for me as others log off. Thank you again.